today. And oh, recording in progress. And that we can share work from this program and all the amazing findings that our community has provided us. Before we fully jump in, I'd like to introduce the host of this webinar. I will be one of the hosts, but I'll go on ahead and pass it over to Shannon Kolzovich that can talk a little bit about her work.
Hi, Aston, and thank you so much. And hi, everybody. Thank you so much for being here to share space with us. We are so excited to present our survey findings. I am Dr. Shannon Kozlovich, she, her, hers pronouns, and that's doctor as in scientist. I am not a medical doctor. I'm really looking forward to sharing all of this information with you in the next hour.
Yeah, thanks, Shannon. Again, my name is Aston Georgia Williams. I'm a program coordinator with the network. I've been with the network for 3.5 years and so happy to be working with Shannon on this program for about almost 2 years. So yeah, excited to share all the information that we have with you all today. Next slide. I will begin with a small bit of housekeeping. This is a webinar, so that means that we cannot see you. However, we're still super excited to be able to use the chat feature in this format. So there is a Q&A if you have any questions. Feel free to throw them in the chat and we'll answer them towards the end of the presentation. Through our 2 hours together, you will all get to know a little bit about our program. You'll get to know Shannon, who will share all the great details of the survey development, the individuals who took the survey, the results, and the best practices that you all can take with you. From there, for the second hour that we'll be together, we'll be joined by our amazing advisory committee impact panelists that will discuss the importance of this work and bring back all of the great information that they have to share with you. And then we'll talk a little bit about our educational materials that we have that you all can take with you. While we do hope that you're able to stay for the whole presentation today, all 2 hours, we know that some people just have an hour for lunch. So we do want to let you know that this will be a recorded webinar and we're happy to send it out for those who cannot stay with us for the whole presentation or those that aren't with us today, but are currently watching it right now. Next slide, please. So a small bit about the network if you have not heard of us. The California LGBTQ Health and Human Services Network is a statewide coalition of nonprofit providers, community centers, and researchers working collectively to advocate for state-level policies and resources that will advance LGBTQ health. We do quite a lot of work with our small but mighty team, and we have multiple programs within our network. We have tobacco prevention, opioid prevention. We do a lot of policy work that is both state and federal, and we do a whole tons more. But today we'll be talking about our LBTQ program. Next slide, please. Yes, so the LBTQ Health Equity Initiative, one of my favorites. You can see all of these beautiful faces in the corner that have done this amazing work. These are all the folks that are part of our LBTQ team. And so we get a lot of questions like, why is this work important? The push for sexual orientation and gender identity, SOGI data, has truly intensified, especially during COVID, during the pandemic. We've seen a lot of gaps within SOGI data collection. Now we do have laws mandating SOGI data collection, which is great. But we still need that infrastructure and understanding among data health professionals. And so that is why this amazing work was created and is being done. We do get questions on where is the G in LGBTQ? Why is it as LBTQ? And so this is actually on purpose. We are focusing on lesbian, bisexual, transgender, and queer community members, specifically BIPOC community members as well, Black, Indigenous people of color. We see that these communities, excuse me, face significant barriers to accessing healthcare due to lots of mistrust from medical providers. And with that, that often leads to delays in care, resulting in increased late cancer stage diagnosis. And unfortunately, cancer registries at the state and federal levels do not track cases by SOGI identity. And so we want to make sure this work is happening. We are doing this work under CDPH, California Department of Public Health, and I'm really sad to say that we are actually wrapping up this initiative now on the 31st of March. We'd love for you to get to know some of the work that we've done. We've done quite a lot of it. So definitely visit our website under About Us to get additional information about what we've done and the work that we're currently doing. Next slide, please. Yeah, so here you can see a little bit about our goals and objectives. You can read the objectives below. I'll keep it short on my end, but basically our main goal for this program was to increase the number of cancer care clinics in Southern California who include SOGI orientation or sexual orientation and gender identity, SOGI data in patient medical records. And so we did a lot of work these past 2 years. We've created educational materials, which we'll see very soon that we want to distribute out. We've hosted the LBeQT quarterly webinar series, which you may have been a part of. We also have recordings of that on our website if you've missed them, which have been great conversations with leaders in the field about how we can make sure folks are understanding SOGI data. We've provided on-site training. We've provided technical assistance to different organizations. We've done so much. And so it's been a really great process working with the team and working with Shannon on getting all of this together. Shannon will be talking about one of the major things we did was our survey that we had. And so, yeah, Shannon, I'll pass it over to you to talk all about our survey and all the great work that we did with that.
Yeah, thank you so much, Aston. Part of the LBTQ initiative that we submitted involved going out to LGBT communities and asking all of you to tell us what it is that you need to feel most affirmed when you walk into a medical setting or when you see a survey and you want to answer the questions. When we were thinking about this, the network had this idea around the same time that the country was struggling with the fact that there are no standards for asking about sexual orientation or gender, no like set questions that everyone agrees are the right questions or the right way to ask it. And these questions don't appear on the census. So we have absolutely no blueprint for how to do this. We also, at the California Dialogue on Cancer, the Health Access and Disparities Work Group created an underrepresented data project all the way back in 2001. And we originally designed this to be just one survey that we could talk to cancer center administrators about and be like, hey, what are you doing for SOGI data collection and how can we help? And that turned into us really getting back some interesting information on we need to know also what the patient population thinks about demographic questions that go to cancer centers. We need to talk to providers and clinicians, and we need to talk directly to the LGBTQ plus community. And so this survey, in conjunction or in collaboration with the LGBTQ Health and Human Services Network, is fulfilling one of the 4 surveys that the CDOC Health Access and Disparities Work Group was aiming for. And we had to find funding for it because CDOC does not get funding to run the surveys. All of the other surveys that we're doing on this project are done out of volunteer opportunities for us putting together the survey, or they're directly hosted by each individual cancer center that wants to be a part of the survey and the pilot surveys that we're doing. So the LBTQ initiative was the perfect place to be able to nest this into and as a piece of a grant that the California LGBTQ Health and Human Service Network was applying for. And where I came in was I'm the evaluation consultant for the project. And I also helped connect the Health Access and Disparities Work Group with the advisory board for the program here at the network so that we had a combined group of folks who were developing the survey, both from a perspective of we have a lot of other surveys and we want to be able to compare them to each other, and from the perspective of we need a survey that has all LGBTQ plus communities feel as included or affirmed as possible when they are responding to our survey. We launched this survey in March of 2025, and the eligibility criteria were adults that are LGBTQ plus, intersex, and or two-spirit. So the first thing that people ran into was an eligibility questionnaire. They had to identify with these identities and say that they were part of our communities in order to have access to the complete survey. The survey was accessed 804 times, 792 were non-Blake responses. As it turned out, June was a very heavy month for a bot incursion into our survey, where we had to remove a great deal of responses because we could not verify or validate that they were from actual people answering it instead of bots getting through the survey. So we were able to end up with 289 eligible and validated responses. And that brings us to who answered our survey. And that answer is all of you. You are the ones who answered. The youngest person who answered was 18. Our oldest respondent was 70. And our average age was 35, which we thought was pretty good representation of the LGBT community in California. We also asked some demographic questions. We asked you to tell us who you are. And we got a pretty good distribution of folks across the LGB continuum for sexual orientations. And we also, interestingly, had 16% of our respondents choose another term that wasn't listed. And a majority of those write-ins, like I think a little over 90% of those write-ins were written in for queer. So based on this, moving forward, we're hoping that the demographic questions now include queer, because 16% of people selecting a different term that's not listed is a very high percentage. And then we also asked folks to tell us about their gender. They were given an option of select all that apply with the options that you see on the board. We had 24 folks say that they are transgender, and every single person who selected transgender also selected either woman, man, or non-binary. So we were able to really get a look at what does our population look like. And it looked like a pretty diverse group of LGBTQ plus folks in our community here in California. And then we also asked about race. You can see the race options. We had a 54% white, so we didn't quite hit that oversampling of our BIPOC communities, but we did give disaggregation options for everyone who selected Asian, Latina, or Native Hawaiian and Pacific Islander. You will not see any of the Native Hawaiian Pacific Islander disaggregation data because no one who selected that also opted to give a disaggregation option. Are the folks who selected Asian, we had a really broad and diverse sample of Asian communities who participated in our survey. And in terms of our Latina population, we had about 50% that were of Mexican descent and just under 50% who had a wide range of other Latina identities as well. So from there, those are the people who are part of the answers that you are going to be seeing today and some of the discussion that we're having. I wanted to make sure that you understood who it was that responded to this survey before we get into what they said. I also want to start by saying those of us who are LGBTQ plus may have a hard time hearing and listening to some of the responses, because when we asked you to give us information, when we asked you as trusted messengers to tell us your stories, you did. And sometimes hearing those back from your own LGBTQ plus community can be really difficult. So please, all of you know that it is okay if you need to take a step back and a step away from the computer, take a deep breath, put it on mute for a moment. Don't necessarily read every single word that is on every slide, especially if there are quotes there. I also want to say that anyone who is here for the CHES or CHES CEUs, there will be a QR code for you at the end of the data presentation. It'll be shown right around 1 o'clock, and you're required to respond to that in order to claim your continuing education credits. As we were going through the survey and the answers, we came up with 5 best practices that we really think all of the survey data fell into and supported. And we'll go through each of these one at a time, talk about how it's supported, put it into a cultural context and perspective, and also let you know what the data is that came through that led to us developing this. I am a scientist. Like I said at the beginning, I always start by defining terms and looking at language. So the very first best practice, which are in no particular order and they are all equally important, the first one we'll go over is how much language matters. The survey question that we'll really be looking at are, we provided everyone who participated in this survey with the definitions of sex, gender, and sexual orientation that is provided on the back end of the most commonly used electronic medical record system in California. And then after providing that definition, we asked, based on this definition, what's missing? How can the definition be reworded in a way where you feel most affirmed and seen when presented with this definition? Because being affirmed and seen is necessary, especially if you want to feel like you are safe and develop a trusting relationship with your healthcare provider. So first, I just want to acknowledge the fact that everyone hates the question of sex assigned at birth. The common theme that came out of this was, leave this question out. Why are we still asking it? Why are we even asking it? What does it matter? And a lot of it, from my experience, I know it has to do with medical billing. So if it is absolutely necessary to include this as a question in your survey or your medical setting or your practice, please keep in mind that sex does not equal gender or gender expression, and that should be included in your definition. Leave out the terms medical or biological, and use an organ inventory to determine care needs. We do not need to be using this specific question to determine someone's care needs, someone's needed cancer screenings, or anything like that. There are a lot of cisgender people who do not have organs that we are consistently asked to get screenings for or reminded. And that can be just as invalidating to someone who is cisgender as it is to someone who is transgender. And just note that California identity papers include male, female, and non-binary. So if you are asking a question about legal sex, you really need to include all legal options for that category here in the state of California. When it came to gender, people really wanted this definition to speak to the empowerment that different terms for gender can give to someone. The definition needs to address the difference between gender and perceived gender, between how you feel about yourself and how society treats you. In English, gender terms include age. We have girl and woman and boy and man. And they also expand beyond man, woman, non-binary. This isn't an LGBT 101 presentation, so you can look up the terms for gender, but just know that there are not only 3 options for gender. And when you are creating these definitions inside of your organization, bring attention to the difference in gender and gender expression, because the clothes that someone wears, the color of their hairstyle, their makeup style, that is not gender, that is expression. And knowing the difference between those and ensuring your definition recognizes that is extremely important, according to our respondents, and also just definitely. For sexual orientation, a lot of people really came down to asking for clarity in the definition. The term attraction, if it's included, should add granularity on the differences between romantic, sexual, and emotional attraction. When listing examples of sexual orientation, make sure that you include aromantic and asexual identities. And acknowledge that sexual orientation is fluid. We don't have the same sexual orientation or the same term that we use to define it throughout our entire lifetimes. So when you're putting this into practice, the way you define terms in the background, it matters. Because even when your terms are not public facing, the definition that you use influences how your organization, your clinic, your providers, your employees, your staff, the people out there doing data collection for you for surveys, it influences how they act. You need to be intentional about your meaning and about your definitions. So really quickly, because these are always the most commonly asked things, and I just want to touch on them really fast, LGBTQ plus is an umbrella term. When you are picking an acronym to use for your organization, pick the one that includes the identities that you actually serve. If you do not have specific intersex inclusion in your programs, you can go ahead and add the plus instead of the I in your acronym. And it's the same thing with directly serving two-spirit communities. They may or may not consider themselves part of the LGBTQ plus community. So pick a term that represents what you do. And above all, do not allow the T in LGBT to be silent in your work. When it comes to the terms transgender and cisgender, these are adjectives that describe someone's gender. Transgender women are women, that is how language works, and transgender men are men, that is how language works, the same way that cisgender women are women and transgender men are men. Not all non-binary people consider themselves transgender, just as a note. When you are thinking about language, you need to practice. You need to practice using neopronouns like they, them. They're becoming very popular. If you are in a medical setting, you should really steer away from terms and terminology that link a body part to a specific gender. That's not how gender works. And mirror the language that people use for themselves. That brings us to best practice number 2. And after the group of us looked through all of the responses, we came to lead with empathy. This really is what we need for anyone who is out doing data collection, for anyone who is analyzing data that includes LGBTQ plus data. You need to understand what the community is facing and how the community sees or hears the wording that you opt to put in there and the care that they're receiving from you. The survey question that really went into this for us is, we asked the following: how comfortable are you in responding to, and how willing are you to answer the following demographics in a clinical setting? We included a lot of different types of demographics. We included age, income, insurance, race, ethnicity, language at home, gender expression, sex at birth, sexual orientation, preferred name, and pronouns. Those were all of the options, and everyone was asked, how relevant is every single one of these? How comfortable are you responding to them? How willing are you to answer them? We're only going to be looking at the SOGI, or sexual orientation and gender identity, pieces of that for this presentation. Our communities see it differently. Like I said at the beginning, CDOC did a cancer center patient survey in summer of 2024 is when we collected most of that data. And for the most part, the greenish grayscale color is the cancer center patient data. For the most part, the patients that were not explicitly all LGBTQ plus folks found gender, sexual orientation, and to a lesser extent sex to be irrelevant to their care, but they're still comfortable and willing to answer the questions. And you can see that because the levels of uncomfortable and the levels of unwilling responses drop drastically from the responses that say they're irrelevant. On the other hand, queer folks or LGBTQ plus folks, we see our sexual orientation, our gender, and our sex as very relevant to our care. But we are uncomfortable answering those questions. It is more uncomfortable for us than it is for the cancer center patients. And the reason for that is because of our experiences in your care and our experiences in other people's care before we came to you and our experiences out in the community at large. And folks really let us know what it is that made them uncomfortable. Anyone who answered that they were uncomfortable, unwilling, or found something irrelevant were given a text box to tell us a little bit more about why. And the answers for uncomfortable fell into three fairly distinct categories: about being uncomfortable because of fear of mistreatment, about respondents saying that some demographic information, really, my SOGI status depends on the context that I'm seeing the doctor for. And some respondents were uncomfortable because they have been mistreated and judged and also received subpar care in the past. And they gave us a lot of information about some of these things. And it made it an incredibly emotional set of data to do analysis for. Respondents are also like LGBTQ plus respondents told us that their unwillingness comes from fear, and really fear of our current environment, fear that answering these questions could potentially hurt them. They only want to disclose this if it's relevant to their care. And when we think about these kinds of responses that we got, what our study really shows is that you need to change the way that you approach LGBTQ plus communities in your settings, in your care, in the way that you analyze data or talk about the LGBTQ plus population that comes into your space. Our medical mistrust really has been built through historical discrimination, current political environments, and the very real ways that we are treated when we step into medical offices. And when we say lead with empathy, what we mean is we need you to know that these experiences have happened to us. They probably have happened to us in your office, even if it wasn't you, by another staff member. Even if you had the best of intentions, it could have also been something that you said. And in addition to that, the background stress that we walk into and out of our houses with every day has been increasing because of the political rhetoric and the attacks that we have been under increasingly since 2019. Every single year since 2019 has been a record-breaking year for anti-LGBT legislation. And this year looks like it's going to be no different. I checked these numbers today. We are at 489 bills across 42 states, including 7 of them that have been proposed here in California. The argument of, but they might not pass, that actually doesn't matter, because it is the language, it is the rhetoric on the news, it is what we hear when we're standing in line to get our coffee. It is the commentary or conversational shrapnel that we hear when we are out at restaurants. And it's also the way that people feel more emboldened to treat us since all of these attacks started. This compounds the level of minority stress that we have been under. This compounds any type of internalized stigma that we have about ourselves, the social stressors that we face out in the world, as well as the increased amount of discrimination that is legally allowed to happen to us, both here in California and anytime we step foot outside of this state. So we need you to ask these questions. We need you to continue to keep sexual orientation and gender in your intake forms. We need you to keep them in your electronic medical records. We need this language to be normalized and to be used everywhere so that it can combat a lot of the political rhetoric that is out there and the attacks that we have been under. Our survey asked a lot of questions to LGBTQ plus folks about how and when and by who and how often sexual orientation and gender identity data should be collected. And we'll go over some of those. One of the questions was, what's the ideal way to provide demographic information to your medical providers? And as it turns out, we want to be able to answer those questions ourselves. Like, please write them down, give us a box to click, give us a checkbox on a form, tell us where to find that information in the electronic medical record. A lot of this is because staff has asked these questions so wrong or made a lot of assumptions about us or changed the way that they treated us after we asked the questions. It is so much easier and you will get so much more of us answering them if you just stick these on a paper or an electronic medical record somewhere where we can answer them. Right now, with the current level of training and the current level of comfort that a majority of our health institutions have displayed directly to our community. We also had about 10% of our respondents that opted to leave a write-in response about this and kind of give a little bit more nuance to how they answered it or why. And so many of these responses spoke to the fact that even when you are trying, even with the best intentions that you have moving into this space, without the proper question, without treating these questions the same for everyone, you are still missing the mark. So when we say, ask us these questions, we don't mean ask trans men every single time they come in if they are still identifying with he, him pronouns. That is not necessary. If you are not also doing that to every single cisgender man that walks through your doors, you should in no way be singling out your transgender patients and asking them that every single time they come in. We will let you know if anything has changed. If you give us the option to change this information, let us know where to find it. Let us know how to make these changes. When we have different terms, when we find more out about ourselves, when we discover more about who we are and how we move through this world, we will let you know. So please, when you are asking these questions and you need to ask these questions, ask them the same to everyone. Treat LGBTQ plus people and their sexual orientation and gender identity responses the same way that you treat your straight and cisgender population that comes in, because we all have a sexual orientation. Straight or heterosexual is a sexual orientation. We all have a gender. Cisgender is an adjective. Cisgender is an adjective for women. Cisgender is an adjective for men. We all have a gender. So please, it should all be asked in the same way. And if I didn't say that enough, I will probably repeat that a couple more times before the end of the presentation. Don't worry. We asked folks how often we want to be able to update SOGI information, and 77% of our respondents said anytime. We want to be able to do this anytime. Not only that, but we want to be able to do it on our own. It is fantastic because a lot of electronic medical records have that data available to be accessed anytime anytime you want to go in and change it. It really depends on what EHR your particular provider uses. And so you can go in and ask and you can say, hey, where is this? But not only that, don't put the onus on your patients. Let people know that it is open to change. Let people know if you have paper intake forms. My physician's office still has paper intake forms. There's no way that I could change anything that I put on there the first time I went unless I physically speak to someone about it. It would be nicer not to have to do that. And so just making sure that you look at your processes internally. Should SOGI questions be asked along other side demographic questions? 95% of people said treat our sexual orientation and gender the same way you treat our race and our age. You don't have to re-verify every time. You should leave it open for us to have that data change as it changes in the system. And then we also asked, is your sexual orientation or gender identity documented in your medical record? And 77% of our respondents said yes, it's in there. We are answering those questions. So please continue to have them available. As you're putting this into practice, keep in mind that LGBTQ plus Californians were clear. Our questions about sexual orientation and gender identity should be asked alongside other demographic questions. We want to fill our responses in on our own, and we will let you know if everything changes. And again, above all, be consistent. Treat these questions the same for everyone who comes in. And when we say be consistent, we mean be consistently good. Make sure your staff understand what they're doing. We asked folks kind of what changes, like what's different when you go into a medical office? Which of the following, or we specifically asked which of the following impacts or changes how relevant, comfortable, or willing you are to answer questions regarding your sexual orientation or gender in a clinical setting. And we gave the following 3 options. It was a select all that apply. And over 50% of our respondents said it's everything. It matters how well we know you. It matters if we have been to see you before. It matters if we have a nurse there that we're connected with. All of that stuff matters. It matters what type of provider you are. It matters if we're there for a gynecology visit. It matters if we're there for a broken bone. Like these things matter to us. We need to understand why something might be relevant before we answer it. And the setting. So many times, especially when you consider like emergency room settings, when questions or histories or things are trying to be asked of folks, understanding that emergency settings might need you to ask something out loud and in a place that doesn't necessarily seem private. You also want to make sure that you follow up later after someone is no longer in that emergency situation to make sure that all of their demographic information is correct. And also, it really, like if you have your medical assistants or the people at your front desk asking people questions about themselves, and there's other people in the waiting room, just know that some people are going to be less comfortable with a whole variety of questions when it's in settings that are a little bit more public. When we asked people why they are uncomfortable or unwilling to answer questions, most of what it said was they're scared. We're worried. We're worried that we're going to receive poorer care. We're worried that we're going to receive judgment. We're worried that it's going to change how you treat us or how you talk to us or how all or some of your staff might react to us. We know that this might change the type of care that we're given, depending on different types of settings. When you think about how many lesbians are told that they don't need pap smears, and these are actual things that folks told us have happened to them. It's really a matter of this is how we are being treated in your clinical care. And the way that you combat that is making sure that your staff is trained, because our common themes fell into fear of future medical discrimination or the fact that we have already experienced medical discrimination. And you have all of the power to change that. You have all of the power to make sure that the training is ongoing, that you are doing what we need to build back trust with LGBTQ plus communities that you have lost through real and perceived actions. Cultural competency matters for all of your patient-facing clinical staff, for your providers, for your billing personnel, for your health data analysts, for your data safety folks, for IT. Really, all of your staff need this training. And we also need to know what it is that you're doing with our data and where it goes. You need to be transparent with how safe we are. So many of us and LGBTQ plus folks are waking up every day to the news or new news of some new state law or court case that could take away our identity documents, that could mean our marriage isn't recognized in some states, that could remove our ability to get married in the future, that people are fighting to remove our privacy and our bodily autonomy. So we need to know what policies you have and what your data security is like. That standard HIPAA form that you give us to sign when we first show up to your clinic is not enough. That doesn't tell us whether or not you will comply with a request from a federal agency to disclose who all of your transgender patients are. That doesn't tell us what your data safety precautions are and how secure your systems are, especially when we're talking about electronic medical records. So you need to prepare more. You need to let us know how safe our data is, and you need to be honest. Especially stop removing forward-facing DEI or LGBTQ plus language, or if you are removing it, be honest and tell us why. We need transparency. So I just want to let a lot of that sink in for folks. This was a lot of information. I know that we had a couple of questions come in, and I want to answer a couple of them out loud. We had one person talk about a cervical cancer study where demographic information is collected at baseline. And there's also going to be a follow-up survey a year later. And they're asking about whether or not SOGI questions or sexual orientation and gender questions should be included again at follow-up. I always think that when you're conducting a study, which is a lot different than a lot of other medical settings, but yes, sexual orientation and gender identity, and also in a lot of cases, race should be changed or recollected over longitudinal studies. If you look at the changes to race categories just over the last like 40 years in our census surveys, that is a category that changes the way that we categorize people into race and also can open up disaggregation options for since your other study. And for anyone who's not familiar, longitudinal just means studies that are happening for multiple years and following people over time. So yes, you should ask different information or you should re-ask information, especially the demographics where the language and terminology around it is changing. And that includes demographics like race because our language around it is changing, and demographics like sexual orientation and gender because our language around it changes. There are a lot of folks now in the LGBTQ plus community who are adopting terms like queer or may have gone by pansexual and is going by queer now, bisexual and queer now. There's just all kinds of changes that we have to language that describe who it is and how we see ourselves. And so, in short, yes, longitudinal studies should be re-asking demographic questions over time, especially the ones where language is actively changing. Someone asked if providers realistically have knowledge about how safe their data is, or how safe data is. And I actually think that that is a valid point. I'm not sure that anyone can know because of how quickly everything's changing and how much the Supreme Court and different cases that are going through the court system can change things. I do think that what providers realistically can do is be honest, talk about the things that are current protections now, and also how secure those protections are. Say that there's some element of not knowing and understand that you might have fewer LGBTQ plus people answering sexual orientation and gender questions in your system. You still need your straight cisgender people to answer those questions. You need more of that data filled in. You need more of those questions filled in. And in the grand scheme of the entire country, LGBTQ plus folks are, I think, like just under 10%, like approaching that 10% level. So when you're thinking about if you don't have 10% of your patient population that is answering LGBTQ plus in your electronic medical record system, you might need additional training for your staff. But please just keep in mind that you can tell people honestly that we don't know what can change based on federal or state policy for privacy settings. Not a lot of people know that. Not a lot of people know that you want to keep data private, but that you have no power over what's happening right now either. And sometimes that can help build a lot of trust. There's a question about privacy and pediatric patients. I am not familiar with California state's privacy laws on how old you are when you receive privacy in different types of medical settings. So I am not going to be able to answer that about privacy, but I will say that the Trevor Project has an amazing report that they put out where they did their own study, field testing questions and question and answer sets on sexual orientation and gender. And one of the things that they found was that youth are more likely to answer the questions if you need a two-step question to ask about gender and then to figure out whether or not someone is transgender. In a lot of places, people will have a gender question and a sex at birth question and then say, well, trans folks are the people where these two answers don't match. What the Trevor Project did was they tested a gender question and a are you transgender as their two-step question instead of including it in a select all that apply question. So I highly recommend looking up the Trevor Project and going through that report. If I remember correctly, it is from 2003, or sorry, 2023. I could be wrong though. They've put out a lot of reports. If I can remember what it was, I will send that out in to all of the participants. All right. Someone asked about the geographic representation in California. I will say I have not yet done a heat map for the zip codes that we got back. We did get zip code data from everyone, and it was very well spread out through California. Probably a little bit more population dependent, but we did have quite a few of our partner organizations that were pushing the survey or promoting the survey in the Central Valley, in Northern California, and in California's Inland Empire or the Tri-County South region. So we did end up getting a larger handful than we were expecting of folks from more rural areas in California. And we had intended to try and oversample for folks who usually get less representation. So yeah, I think from there, I am going to ask Aston, or the folks, did anyone see another question that came in that I may have missed in the chat?
There are two questions in the chat, it looks like.
Okay, great. I only had the Q&A up, so.
Would you like me to read them aloud for you?
Yeah, that would be great.
Yeah. Having been through the harsh fights over opt-out for abortion and contraceptive training for physicians. Oh, wait, hold on. Oh, I just lost my spot. Sorry. Oh, Ari just reposted. Are you able to see that, Shannon?
Yeah, so the question
Okay.
was, there were fights over opting out of trainings for abortion and contraceptive training for physicians and grading of Medicare or Medicare reimbursement on repetitive questions every visit. They're asking about thoughts on California physician training. And in my opinion, and this wasn't necessarily asked in the survey, so this is not a data like point from the survey, but in my opinion, physicians should be required to be trained to treat every patient that walks through their door. And I think that when we put in policies, when we pass bills, when we have trainings that are required, physicians should not be allowed to opt out of any kind of cultural competency training for the people who they will be serving. You will have LGBTQ plus patients come into your practice, and you have to be able to serve them. I saw a quote online from just some meme that on an account that I follow that said, if you are going into public service, you must be able to serve all of the public. And I think that that resonates with me a lot. So someone also asked about forms not collecting sexual orientation and gender identity because of the third-party reporting exception. And the question was around how do we make sure that patients are clear on who has access to their information and why. I think I think that comes down to being transparent. And really, the transparency that folks want, they want to know where their information is going, who's going to have access to it, how it's going to be used. That's going to help your patients feel more secure and trust you more if you are letting them know. So yeah, I believe that that is all of the current time that we have. Anyone who needs to take a quick stretch break or just get up and wiggle your body for a minute, go ahead and do that. You are going to come back in just about 2 minutes while we do all of the tech shift and hear from a few people who have been an amazing part of the development of this project and are also folks who exist in the community, and you'll be able to hear their reactions to everything. I will pass it back over to Aston as we get ready. Don't mind the silence for a minute or two.
We'll get our panelists all ready. Panelists, if you want to turn on your cameras, I think everyone is here. Wonderful. Okay, yeah, we'll go on ahead and get started. Shannon, thank you so much. It's always such a joy to hear you present and all your dynamic conversation you have with us and all of, yeah, the passion you have behind this work. It always shows through. So truly appreciate you sharing the work and all the information from our communities. I'm super excited to invite our impact panelists to this space. Today, we'll be inviting 4 of our advisory committee members to join our impact panel. Today, we are welcoming Alexandra Caro, Mars Cruz, Maggie Hawkins, and Phoenix Shetty to the space. We'll have some dynamic conversations with them about what they thought about this information. So yeah, I'll go on ahead and start. We can go in order if you all would like. To start us off, if you could each introduce yourselves and share a little bit about your role and how your work intersects with health data, cancer care, or LGBTQ communities. Yeah, I guess we'll start with Alexandra since you're first here. Is that okay?
Yeah, for sure. So good
Great.
afternoon, everyone. I'm Alex or Alexandra, she, they pronouns. I'm a lead community health associate with Cedars-Sinai Cancer's Community Outreach and Engagement Department. As part of my role, I help lead a lot of our LGBTQ plus initiatives, including our Quit Alliance program, which is our tobacco prevention program. My specific grant focuses on policy advocacy with LGBTQ plus communities in order to pass smoke-free policies in a few local jurisdictions. On top of that, I also run a trans research advisory committee. So we work with cancer researchers here at Cedars and community leaders, TGI community leaders, to form research priorities and improve cultural competence, inclusion, and equity in our cancer research. So yeah, really happy to be here. I work a lot with data, both in like my data collection and evaluation purposes for our tobacco grants, and also in the advocacy and equity work that I do for my research advisory committee. So really happy to be here.
Yes, thank you for your awesome work, Alex. Mars, we'll pass it over to you.
Hi, good afternoon, everyone. My name is Mars Cruz, pronouns she, her, or they, them. I am the Title IX Prevention Coordinator for the University of Colorado Anschutz. I originally joined the panel a bit earlier in my career, and I'm so happy to be here. How my work intersects with the presentation today is that as a prevention coordinator dealing with a lot of civil rights law, so Title VII, Title IX, I have to ensure that a lot of the activities done by the university, which is a medical campus, and specifically for oncology, we are one of the only NCI designated centers within the Rocky Mountains. I have to ensure that all of the activities that we do and our staff, our employees, our students are adhering to a variety of civil rights law. And I think, we'll talk a little bit more about it during this panel session on why it's important that upholding certain equitable data collection is upholding that civil rights law as well. So happy to be here.
Thank you so much, Mars. Maggie, we'll pass it over to you.
Hi, I'm glad to be here today. I'm presently a DRPH student at Claremont Graduate in Southern California. My area of focus is LGBTQI health. I'm also adjunct faculty in public health at Cal State LA. I have previously in the past worked on CDC projects that trained HIV clinicians to have honest conversations on sexual health with HIV positive people. I also came onto this project because I was doing some field work with a group called the Light Foundation, which stands for Living Your Truth Empowered. And I was specifically looking at support services for queer breast and chest cancer survivors. And then lastly, I just want to say, in terms of my spouse and I, went through a situation back in 2021 where she was diagnosed with uterine cancer. And I'd like to share some of the experiences we had dealing with cancer care clinicians at that time. And thank you.
Thank you, Maggie. Phoenix, we'd love to hear from you.
Hello everyone, my name is Phoenix. I work for the Department of Healthcare Services as an analyst one. I use she, her, or they, them pronouns. I am here. I like to talk about intersectionality because I'm a person with a disability who also happens to be queer. And what I found is the fact that services available for persons with disability don't include queerness and vice versa. So I wanted to increase the I want to I want to I want people to acknowledge that there are people who have like multiple intersectionality identities. So it's important that we make sure that we help with all of them. For example, if if it is if you're be only available via phone call, it might not be as helpful if someone is deaf or hard of hearing. That's an example, and so on. So I want to bring some awareness to this issue. Sorry, it was like a doorbell. It has that Halloween music. Sorry.
No worries, Phoenix. Thank you so much, all. Super excited to get into conversation with you each. My first question is thinking about the findings overall, how do you see these insights applying to your own work or the systems that you work within? And where do you see opportunities for changes or improvement? Anybody can jump in.
Well, I'll say as part of the Trans Research Advisory Committee that I run, we work a lot with researchers to make sure that their studies are being culturally competent and inclusive of trans communities. So a big part of what we do is give suggestions for how to ask these SOGI data questions. We've actually developed our own sex and gender questions, and I think that seeing the results of the survey has validated a lot of that, but also given us a lot of things to consider. So it's helpful to have the insights of just the community at large and not just the committee members that are giving input. On top of that, I also lead, or I'm a co-chair of our LGBTQ plus employee resource group at Cedars-Sinai. So we also work more on an institutional level to make sure that Cedars is treating our LGBTQ plus employees right. So a big part of that, I've been able to actually connect this group to some folks at Cedars who work more on the clinical side to make sure that we're continuing to improve our SOGI questions because Cedars actually does a pretty good job of that, but there are always ways that we can improve, until we get to the day where we can just have people self-identify and have, a way to code that easily. I think that we're continuously going to be looking for ways to improve. And also just in my personal work, even like I said earlier, creating small surveys for, you know, consumer testing or for like public opinion surveys that I'm doing through my tobacco grant. That's something to consider about how we ask those questions as well. So yeah, I think it incorporates into all the work that we do.
Yeah, I would definitely second that, Alex. I mean, I think as someone who, first of all, as a student, went looking for the data and realizing that how inconsistent it was. So, what the survey talks about really, really rings true for what I've found in the data and how the laws are changing, but not necessarily being enforced. I think that that's really interesting. And of course, since the survey was done, things have changed even more in terms of the political environment. And so I appreciated the portions that were talked about there. The other thing that I wanted to bring up too is someone who trains public health students. I would really like to see public health students get more of this kind of information in basic epidemiology classes and basic biostatistics classes to really understand better how this is just another part of asking about who people are rather than it being singled out as something different. I think that that part of this really rings true for me as well.
If I could jump in, I do want to echo both Alexandra and Maggie's point. I think Alexandra, you had mentioned and talking about how it influences how your organization treats its LGBTQ plus employees, and I think that's where I see a lot of this data being very pertinent to my work. So I advise a lot of the different divisions of medicine here at CU Anschutz on how they can conduct their activities in a way that is equitable to not just the LGBTQ plus population, but also to different protected classes. And I think the way that folks design inclusive like electronic health record collection, data collection, those conversations are going to be difficult at times. If you go behind the scenes and you see how LGBTQ plus staff members have to always fight for these things to be included within their projects, within their systems, and being able to demonstrate that there's a really high efficacy rate of folks within this target population who are willing to go above and beyond to provide accurate data on their gender identity and sex as long as they feel safe, they feel empowered to do so. I think is really important to kind of tip the scales for those folks. And I think to comment a bit on Maggie's point about how the laws have recently changed. By the way, I do have to preface this. I'm not a lawyer. This is not legal advice, but especially in the wake of the United States v. Scrimetti decision, where we saw a huge wave of bans on transgender care for minors that hasn't stopped folks from demonstrating a high efficacy rate when they feel safe. And that just really does speak a lot to the community. I mean, there's a lot of nuances of like, where Tennessee was located, which district court is California located. But to a layperson, they see a lot of these incoming care bans, for minors, and they're thinking, oh, this might happen next for adults. But if I still feel safe and supported in my clinical needs, I'm still going to report this data, regardless of how scared I might also report feeling about the federal government. So I appreciate, folks aren't shying away in this conversation about how the legal ramifications have hurt our community, but also how projects like these are really stepping up and demonstrating that We're not going anywhere.
Yeah, I would like to say that while I don't work with data on the first hand right now, but tomorrow I have an interview for CDPH, Department of Public Health. Hopefully I get it, and if I get it, then I would be working with these data a lot, and I would love to work with such data, and also I want to. This is one more thing that's I say that instead of like having more options for gender on ID, I believe that the true point of action should be just eliminate that column entirely because it serves no purpose. Instead, I say that the most important column that is never on ID should be the blood group because that's more crucial.
Awesome. Thank you so much each for sharing. I'm really interested in understanding what stood out for each of you the most. I know Shannon shared a lot of information in those slides, and it seems like y'all were bringing up quite a bit that stood out. I would love to dive deeper into what was the most impactful slide or impactful information that you may have received after, hearing about this information.
I think one thing that stood out to me was seeing how people want the option to be able to answer their own SOGI data questions, to be able to access that whenever, and the opportunity to change that. So to connect that back to even like Shannon's answer to Amber about asking those like SOGI data questions upon follow-up, I really liked Shannon's point to the fact that language is ever evolving in our community. We're always evolving both personally and in how our community sees language. And so just seeing even like the fact that the vast majority of people who selected anything other than LGB were queer. So, that for me says that we should definitely be including queer in future surveys as one of the main categories. So I think that is something that's very impactful, just knowing that a lot of our community would prefer the control in their own hands, because I think that that's something that isn't often done in a lot of medical spaces that are often like gate kept and very strict in that way.
So, yeah, that really touches me as well, Alex, in terms of the level of people want to be empowered in medical spaces, and we're willing to take risks, our own personal risks, to be able to create a dialogue with our providers. And I think something that you said earlier, Mars, about it just really speaks to our resiliency also, like the situation with transgender youth in care, that people are really willing to embrace, this is who I am, and I want to be seen. And it's something that I actually feel pretty emotional about at the moment. And I felt emotional when Shannon was kind of going through this data, because it does feel so good to be heard and seen, and to have our voice out there. I mean, that may sound simplistic, um, but we want providers to embrace the complex human beings that we are, because so many times we are reduced to gender or sexuality, and I think again we're much more complex.
Yeah, I think I first off, Maggie, I don't think it's so we so simplistic to just be like, oh, folks need to be seen, they need to be heard, right? I think very what thing people might think are innocuous decisions, and this will tie into what Alexandra was talking about like, autonomy and decision making, and how I kind of want to comment on what stood out for me the most is that very innocuous decisions, such as maybe potentially putting a disclaimer on these identification forms of like what needs to be essentially collected in regards to SOGI data and why, and even maybe the unfortunate matter might be the potential risk, depending on your whether like a federally funded institution that you might need to send like the data to like the NIH or the CDC for certain grants and care. Like knowing that that is something that you as an organization recognize as a potential fear, and you are willing to put that up front and say, hey, this is what we are using it for, right? Like I'm going to hope that it's going to be the minimum amount needed. And if you have concerns, please talk to your provider. Your providers have been briefed on this and they're there to talk to you about this specific issue. I think the unfortunate matter is that, or silver lining, I would say, is that people can feel empowered to take control of their own healthcare in spite of a really difficult situation. Talking to the provider of like, okay, if I am still just providing this information for billing, I might feel more comfortable. If it's tied to something else, I might not feel as comfortable. I don't know the extent of privacy protection laws in California. And I mean, in general, it's a little stronger than some other states here in the Midwest. But I think, with queer people even feeling empowered to like, yes, I'm willing to have this any kind of conversation with my provider, even if it's not always going to be positive, is a good thing.
Yeah, agreed.
Yeah, and I also I also want to emphasize that I like that they said that adding asexual and aromantic as sexual identity, because I see that those two options are what I call as the least common options. I don't see it in any of them. So when people like me fill the survey, I have to put asexual and aromantic. And I do want to say that there are people who might just want platonic relations, and we should not be like dismissing them. And also I don't want to I want to say that I also want to emphasize that A stands for asexual and aromantic and not allies, because many people think allies are part of the community, but no. Allies are considered out group who are supportive. They are never part of the community by themselves.
No, if I could add on to that, Phoenix, it's a really good point. I know in previous panel discussions, folks, you had brought up the lack of an ace option or a romantic option. I think, I mean, if I could add an addendum, the amount of additional options we have discussed as a group that would probably be needed for additional clinical studies, it's quite high, right? Like, and people are self-reporting that, which is, I personally think, is a bit uncommon. So yeah, and I think it even demonstrates like how a little bit of educational training can go a long way, because in my personal opinion, these fixes in like the EMS or EHR or whatever you use in your own clinical setting are quite low. Like in Epic, for example, it could be as simple as adding 2 more additional boxes, and that goes a long way for making folks feel affirmed.
Now, I wanted to thank you, everyone, for this discussion. And really, it's been a wonderful discussion. I also wanted to talk about it just from the caregiver patient perspective. And when my spouse, she was diagnosed with early stage, gratefully, uterine cancer in 2021. Some of that coming off of the pandemic, not wanting to go in, all the things that we saw during that time. But one, it was quite a journey to even get her diagnosed. Doctors did not look at things in her chart, for example, that she had never had children. So they had difficulty diagnosing her. I mean, there were things like that had gone on. But I think the thing that was remarkable to me, that I live in inland Southern California, in a region where it's a big metropolitan area, but we do not have a lot of gynecological oncologists in this area. And we had 2 at our medical center that we were dealing with. And we had really uncomfortable conversations with both of them. They finally did the surgery, which turned out fine. But I remember being in one of the exams with one of the doctor that did the surgery, and he was asking us questions about whether we use sex toys. Now, what was crazy about it, and this goes back to what Shannon had brought up, and I've been a sexuality health educator, so there may have been a context, but it was like he asked this question out of context. And I kind of sat there, we both sat there for a minute, and it was like, okay, why are you asking these questions? And I think to go back to the language matters, how questions are being answered, what the context is. I mean, I think there were some really disturbing things just in that one interaction. I contrast that with, we had got a consult with City of Hope in the Los Angeles area, and they were amazing because one, they brought us in for a social work visit together to talk about the impacts of the cancer on us together. Heard the doctor that we consulted with fully acknowledged us as a couple and dealt with all of that. And I think that, sometimes people are like, well, why does this data matter? But it's like fully seeing who we are, who her support system was, how we would work together through this cancer experience really made a difference, And, and I think that that's important for us to know.
Absolutely. Thank you, Maggie, for sharing that personal experience. And thank you, everyone who has shared so far. Going off of what you were saying, Maggie, about language matters, one thing that came up repeatedly in the surveys was the experience of providers over asking about pronouns when sharing identity information. From any of your perspectives, what do those experiences tell us about how systems are currently collecting SOGI data?
I think, yeah, sorry if anyone else wanted to go first. I just want to jump into it. I think over asking on pronouns tells both, and this might sound harsh, an unwillingness to learn beyond the bare minimum of what might have been required by your organization, and also a stubbornness to learn from, and I'm going to, infer possible experiences you might have had with LGBTQ plus individuals. I work with, and I'm going to try my best not to throw any specific provider under the bus in the state of Colorado. But when I've worked with folks where it's like just overusing on pronouns or relying on very outdated information on like what is a non-binary person, what's an asexual, what's an aromantic person, right? How to ask a person if they are non-binary, for example, or queer in the doctor's office, right? I think it demonstrates both that not only you're not willing to learn, you just don't care about it. And that's unfortunate because, what we know from our training where it's like, that's the population that needs it the most. Like if they're dissuaded from getting healthcare for something, for example, for the first time, they are just not going to seek it as all, and they're going to have more chronic side effects or health conditions later down the line. Especially since I think, you know, in the current zeitgeist that we live under here in the US, I think the bar to be inclusive is extremely low, and yet people are still unwilling to do that. I think one last thing, since we're talking about provider patient, I'm going to infer it's like a mid-level practitioner and above. What does that say of how they navigate and lead their paraprofessional staff, their clinical staff, if they're not willing to go and utilize the basic educational tools that many organizations, including the LGBTQ plus services network, got to give a quick shout out. You guys have really good information. How do they lead these conversations within their staff? Because a lot of times, providers, not only are they interfacing with patients as in a level of power and privilege, but they're also the directors, the managers, right? How do you think they're going to navigate this conversation with like a queer CNA or a queer desk receptionist who might come to them with a problem? So yeah.
Those are amazing questions, and I do think we need to dig deeper. And this whole, I hear you. People that get annoyed, annoyed with the pronouns, that can't get the pronouns, and sometimes I've felt, again, from more of a caregiver patient perspective, like if things are in the chart, my expectation is my provider is going to look at that and have a sense of who I am. My primary care provider does, so an oncologist should be able to do that as well. And then, there's this whole issue of literally when you're in an oncology cancer care setting, that person in many cases literally has your life in their hands. And so all these other things we're talking about in terms of people's level of fear and concern definitely gets magnified in that kind of a situation in terms of, is this person going to give me biased information, not give me information because who I am, and it may literally end my life.
Yeah, talking of like misgendering and all, I also find it sometimes interesting that it's like even inside the restrooms, you are not immune to misgendering. I find it really like annoying and strange that people call me he, him even when I'm inside a women's restroom. They don't have problem, but they still misgender me inside. I'm like, what? Yeah, and I do want to say that usually misgendering is more common when you are on phone call compared to like using a portal or something because it's very hard to like fine tune your voice. So yeah, I just wanted to add like this awareness to that. So having like a portal, not only would it help for like in terms of misgendering, but it also helps if someone is deaf or hard of hearing.
Yes, thank you so much for sharing, Phoenix, Mars, and Maggie. Yeah, just read the chart. We appreciate that. We do have a participant question. Since we are talking about language matters, what are some of the specific language or cultural nuances that should be considered for SOGI, for SOGI data collection in different languages?
I think one important thing is not relying on like direct translation. I think oftentimes when you go to like services, or now a lot of people are using AI. Before that, it was like Google Translate. Where you don't bring in people with that community perspective, you might end up, directly translating something that means something completely different in that language's context. So I think about it in as somebody who like speaks Spanish. I know that there are a lot of terms that we use in Spanish that there aren't necessarily direct translations for, or vice versa. And so bringing in people from those communities to help with translation or to modify translations once they're already done is, I think, like a big part of that. A big way to bring in those like cultural nuances, because on top of that, you also can't rely like single people to be the authority for the entire population. So yeah, like I'm a Spanish speaking trans woman, but I can't speak for all Spanish speaking people, or all trans women, about how they like to be referred to. I can't speak for non-binary people who speak Spanish and how they would like to be referred to. So I think it's about what works for the community, getting that community voice.
And to add on to that, I think a small addition, I think it's a really good point, Alexandra. I think also potentially adding on to like data collection forms or somewhere within your clinic that if you want to ask more about the reasoning why you chose the way you did on like, translations for like Latinx or Latinate, I'm just gonna, give an example. Please please ask, right? We would be happy to tell you that methodology. I honestly think it speaks to a larger conversation that you are having these conversations with your staff on what to put onto your forms, because I'm going to take a shot in the dark. Your staff live in that community as well, more often than not. If it's okay, folks, I did see a question that I think was rescinded in the chat, but it was a really good one on how to kind of lead these conversations. I think it was a nurse who was asking how to lead these conversations that we're having right now. with their staff and, how to move that forward to be more inclusive. First off, whoever did write that, I do want to shout that out. That's a really great question. I think from my time working with like labor and like civil rights compliance, the best way to do that is take the tools that we have done here that the LGBTQ network has created. If you're comfortable with sharing that with your staff, if they're willing to have tough conversations. Now, if they are not, or as we've also talked here, that some providers might not be willing or might have a hard time of having tough conversations, use that as an opportunity first to build that trust, to talk about things like gender identity, race, sexual orientation. And once you've built that trust, I think you can use the many tools that the network has to your advantage. One thing I did share, thank you, Shannon, for posting that. I shared it to the host and panelists, is a really great training outline by the EEOC on navigating respectful conversations. I use this personally a lot as like a baseline on how to build that trust for folks. And then from there, then we can talk about, well, if we're going to be more inclusive for the queer community and data collection, what does that say of our employment practices? How does that say about what we are doing with our queer staff, right? This might be the unfortunate and best time for them to say, you've mistreated me in the past, right? So if you are comfortable leading on both ends, I think not only it demonstrates a willingness to be there for your queer patients, but also for your queer staff.
Yeah, and I think this goes back to one of Shannon's points, which was ask, just ask, and again, be willing to create that dialogue, as you're saying, Mars, with your staff, with the people, your patients, people you're working with. I think that's it seems straightforward, but it's challenging. And the other part of it is all the resources we've just talked about. There are lots of us that have been working in this space that can walk that with you and help you and your staff be more capable in this area.
Yeah, I would like to add that this point goes to both of these questions, like having both hitting both targets with one arrow, as I would say. So I want to say that for language purposes, someone whose first language is the other language that we want to translate to, they should be like given the authority, and we should have at least like a couple or more people, because so that you can have a peer review or some sort, because what if someone makes a mistake, you want someone to catch it. So peer review is good. And also, I want to say that for the question about training, again, training about LGBT people, it would be recommended, highly recommended, if it is done by LGBT community themselves. Again, at least a couple of people for peer review purposes, so that they know they face it on a regular basis, so they would be better equipped to train on them. And so this is what I like to call this as an in-group. So every time I say that in-group, if you're inside a particular group, then you are in-group. And I will say in-group comments or anything should be like more important than out-group things, though there can be some exceptions, but that would be dealt on a case-by-case basis.
Yeah, thank you so much for that. Phoenix, yes, that is so important to be able to have the folks who, are being impacted talk about it, because otherwise it's just hearsay from someone who has not experienced it. So thank you so much for that. I know we have about 10 minutes left of this conversation, so I want to throw in this last question just because I know it may be a longer answer. So considering the current cultural and political climate around LGBTQ communities and data collection, how do you think these findings land today? Do you think responses or willingness to share identity information might look different now? We know that things are changing every single day, not necessarily for the best all the time. And since this was a survey that was put out earlier this year. What has changed? Yeah, I'm interested in hearing all your thoughts.
Yeah, and is it okay? I'm gonna give the perspective from someone who works in Colorado, and we have colleagues who interface from like Wyoming. Unfortunately, like I think it depends, it's very region specific. I would imagine in California that responses might be a bit lower in, for example, the Central Valley region, not just due to like historical demographic needs or health inequities, but also to other things that are going on in the news that might impact, for example, queer immigrants of color. I think that was a question that I think that we somewhat got in the Q&A. I think the response rate might be a bit lower, unfortunately. And I think looking outside of the state of California, if you were to, like, to be very transparent, I think the response rate pre a lot of things that are happening within the second administration might seem similar in a state and region with a similar demographic, such as the Denver metro area here in Colorado. However, if you were to do it again, I think the response rate would be a lot lower, especially if we were to maybe look at it with other states. And I bring this up, I think, not only just to provide an answer to it, but also to demonstrate that the kind of work and the response rate you got first really just shows the amount of work and protections that have been put in within the state of California to protect LGBTQ plus individuals, especially like the unthinkable thing of like having to openly need to protect adult LGBTQ plus care, which is something I can't believe we've had to have this conversation. If you asked me like maybe 6 years ago, like we would have to talk about having to make the frontline transgender adult care across any clinical need, I would have been shocked, but here we are. To just kind of end off that point, I think that it demonstrates also a need to continue these studies and that the way that they are being done. I I hate to be like a harbinger per se, but there is a huge pullback from states, especially not California, in regards to collecting this type of data. You know, and that could be for a myriad of reasons, right? Lots of folks are reliant on NIH and CDC grants. A lot of folks are reliant on Medicaid billing. And because of what has happened at the federal level, especially with DHHS restrictions potentially incoming, folks are already preemptive pulling back. Like, I would be surprised if you even had this webinar in a different state. So I think, moving forward, that folks should take the data, the high response rate, and really tell people in power within your organizations that, there is a high efficacy rate of folks who are willing to respond to this in a positive way, on top of like, all of the moral and ethical reasons why we should still collect this data in the way that we do and still represent our communities in the way that we do.
We've fought for all those letters. Those letters that's right. Those letters aren't just letters, but there's people's lives and histories, and there were people that also died over them. And so when we talk about, well, let's just change the language a little bit because of funding, the old queer activist in me really has a bad gut reaction. I mean, I think we really do need to find all the ways we can to resist and push back. I know, for example, one of the organizations in my area that provides wonderful transgender centered affirming care has stopped using that language publicly and have started going back to underground, like people know underground that we offer it, and from patient to patient. As a professional in public health, I find that so objectionable. Just on a personal level, it's objectionable. But I mean, we really need to have those hard conversations with institutions in our community about how they need to continue to use the language.
Especially if I could add on very quickly, I apologize, Alex and Phoenix, not giving you a chance to jump in. Especially when if folks were to look in their state and within their jurisdiction, that this is my personal biases. I think the Attorney General for California is doing a lot within the confines of institutions to, ensure that the ramifications at the federal level are being minimized. And I think at the very least, for folks who are listening, please implore your institution to not take preemptive actions, right, in erasing queer communities. I will be also honest, it is a different conversation if your organization's counsel is to receive a subpoena by the federal government, but more often than not, organizations are taking these preemptive actions without a request to do so. And what we are also seeing is that more often than not, trying to, lean on some lawyerly speak, the federal government is not pursuing these direct actions. Like, if you're an institution that unfortunately has been contacted by the Department of Justice, that is a different conversation. But if not, employer counsel, employer directors, do not do this. Not only is it ethically wrong, it's also just a waste of time because, like, if you're not being contacted more often than not, then you're fine. It's just, unneeded fear.
Yeah, I totally want to agree with that. I think that this pre-compliance has really been such a vice for so many organizations. I think we've seen so many of these cases play out in the courts and later be thrown out. And by this time, a lot of those organizations have already been dismantled, or a lot of those programs have been dismantled. Or we have to think about, even if they were only dismantled for a few months, a year, think about all the people who lost care, who fell out of care, who decided maybe it's not worth transitioning right now, or pursuing gender affirming care, or getting a cancer screening that's going to make me dysphoric or uncomfortable. And so we really have to consider the long-term impacts that this kind of political environment is causing. While, a lot of us may be in more privileged positions where we don't lose our health care, have more access to those things, a lot of our community members don't. They're the ones that are being most directly affected by a lot of these policies. And so we really have to be considerate of that. And I think on top of that, I also want to say that there have been some studies that show that even in times of political turmoil, LGBTQ plus communities are still very enthusiastic about answering these questions. And so I think it's a good reminder for us to like have a call to action to have folks still participate in research, especially as we see more of these funding opportunities disappear. While a lot of these studies are still going and still recruiting folks, it's that much more important that we have those numbers, that our community is represented, because those numbers are what give us the data to support policy change, to support funding that is redirected back into our community. So yeah, I think that unfortunately, a lot of people may not be as receptive to these responses now, or may not be as comfortable responding to those SOGI data questions. But I really think it's on us to empower them and remind them about the importance of participating in research, and the importance of not letting ourselves be invisibilized because of fear.
And if I could add on to that, I think that yeah, yes, first off, like, yes, we have to keep demonstrating that we're here, that the work needs to be done, or else the life-saving research and resources that are desperately needed won't be there. Before I add on, I also want to just say that, transgender and queer rights, um, in my biased opinion, is the floor right now for just civil rights in general. What your organization or jurisdiction does in response to these attacks on queer rights um, may be unfortunate telling of what they may do in regards to, I will just throw out like Title VII and protected class of all kinds, as we've also seen those protections erode as well. Um, yeah.
I'm pretty sure it was Angela Davis, I think, who had a comment about that, about how like gender equity and like transgender rights represents like so much revolutionary language, or like a movement in our society. And she said this years ago, before we saw this a wave of hate. So I think, yeah, thinking about Angela Davis right now.
Yeah.
Yes, definitely. But it's about bodily autonomy. It's just about what any of us, regardless of your sexual orientation and identity and expression, It's about what you can do with yourself, your lives, the decisions you get to make. And that's very threatening to the powers that be at the moment, very threatening. And, I think queer people are at the heart of that. Um,
Yeah, I also want to add that all struggles of all marginalized communities are like interrelated. Like they just try to divide us, but like most of the time it's like we should stay united instead of like fighting with each other. And I don't know how many of you know that the transphobic machine of the 2020s, it it was an offshoot of the anti-mask movement. It's once COVID started becoming rates started dropping down, they couldn't say like anti-mask anymore, so they pivoted to anti-trans strategies. So that's why it happened like more commonly after COVID, because it came from the anti-mask movement. And also beware of like pink washing and those who divide us and so on.
Yeah, I really want to, I'm sorry to keep going back and forth on this, Aston, but the like intersectional connection and just uplifting like marginalized voices, like by uplifting the most marginalized voices, we uplift everybody else. I even think about organ inventories. Organ inventories aren't just for trans people. There are cis people who have had mastectomies, who have had hysterectomies. There are cis people who have had other bodily parts modified or removed. And so it's ultimately a practice that helps everyone because it ultimately just makes our medicine and practices more objective and more rooted in fact and objective fact rather than these gendered definitions that we put on things. So as much as like we like to think that the way that things are gendered is like how it's normally done or how it's like most, effective, it's really not. So yeah, just wanted to say.
no, it's not. And early on when I was working on one of my projects, I talked with a clinician who was providing gender affirming care. And one of the things she said was just so wonderful, which was it just makes her a better doctor. It just makes her a better provider to have an awareness. And I think you're right. That's how we should think about all of this. This is making us a better humanity. And as always, queer folk are up front. I mean, I think we've done this throughout time, if we're really honest about history. And I don't think that's going to change. And as I think someone said earlier, we're not going away. And if you are a provider and you do have patients that are queer, and you need to be aware of that and take care of them as well as everyone else.
Yes, I love that. What a beautiful ending. I'm like, we're not going nowhere. Mars, Alex, Maggie, and Phoenix, thank you so much for this robust discussion. It was great to get all of your insight, your feels, all of the things to keep us moving forward at this moment. We truly appreciate it. So thank you all. I know we have about 10 minutes left of this whole shindig. So I will pass it over to, I believe, Lou, who will be talking a little bit about what you all can take with you and move forward with all of this information we shared today. So I believe it's Lou, if I'm not mistaken. Lou, will you be taking it away?
Yes, I'm currently adding myself to a spotlight, which feels very odd to do. But yes, thank you so much all for joining today. And I know we went through a whole bunch of information, and because of that, we know how heavy all of this is and how dense it can be. We wanted to create an educational material that condensed it for you all. So you are more than welcome to download that educational material here. You can do so by scanning the QR code or accessing it through our webpage. It goes through a lot of the things that we went into today. It has some quotes, some data, some of the main bullet points to help you all with your own SOGI data collection and implementing it into your own spaces. With that, if you don't mind going to the next slide, Aston. I'm not sure where the other one went. There it is. Okay. We also have a couple of other materials that we created, and I know Mars was also uplifting us about it in the conversation. So we do have some other educational materials about a when and how to include SOGI data, a why SOGI data matters, and then quite a few other webinars that have led up to this very moment today that helped us develop the survey that we did and all the research and all the materials we have at the end of today. So feel free to access those. I also really want to emphasize and bring some suggestions on how you can utilize them into your own spaces as well. Please feel free to utilize any of these resources in your own trainings. That can be, how to, conduct your own surveys and providing these resources as a tool for folks to know when and how to include it, SOGI data into your work and why it's so important. Um, and then also, please feel free to share these within your own community spaces. We want to equip folks with the resources needed. Knowledge is power. And one of the main things that we wanted to do with these educational materials is remove a lot of the medical jargon that is in a lot of other documents. So we wanted to be very inclusive and just be more accessible than past documents have done regarding SOGI data. And with that, we also feel like this is a really important tool for self-advocacy. If you are part of the community and you step into doctor's offices or any facilities that you feel is not doing the greatest job at implementing SOGI data, feel free to print these out and leave them on their desk. Give them the resources and let them know that you have the knowledge here. And giving them the turn on the table to make an impact and do some positive change. So feel free to access that by the link in the chat or by scanning the QR code. And that's all from me. So I'll pass it back to you, Aston.
Great. Thank you so much, Lou. Thank you, everybody, for joining us for this amazing finale from all the work that has been done from everyone. We truly appreciate you taking the time out of your day to come and listen to us today to learn. Shannon, I want to uplift you. If you have anything you want to add about the CEU requirements, and yes, you can say one final goodbye, of course. Come on down.
Hi, everybody. For those of you who hung out with us and stayed through our entire 2 hours, thank you so much for being here. Any of you who want to claim the CHES CEUs, you are required to fill out the evaluation. The link is both in the chat and also on a QR code here. Many QR codes we have for you. I just want to say that for everyone who was curious about how to step into this work, how to get started, how to get your employers to start thinking about it, anyone who showed up because you participated in this survey, because you responded to these questions, anyone who is here because you work with our communities who so desperately need you to be there, please just take my heartfelt thank you. You all are the rock stars. This was how you get started, and this isn't where it ends. So please reach out to the network, reach out to me. We will be here. We're going to be getting this information out there. We're going to be putting it in a couple of different reports. We're getting a peer review manuscript ready to go so that no matter what sector you work in, you will have what Lou showed you so that it is easy to understand. You can take it to your physician's office. As an individual who needs this kind of advocacy, you can take it to your employer. We're going to have a community report that has all these best practices in it. You'll be able to access that. We will share it out to you as soon as that is ready. We're also really hoping to get a peer-reviewed manuscript approved, which means that if you need evidence for evidence-based stuff and a self-published report doesn't work for your employer as evidence, then please, we will have this manuscript out. That takes a lot longer than anything else we're developing. So thank you for hanging in there with us. We will shout that from the rooftops as soon as it's published. And then just thank you. You are all absolute real life rock stars. You showed up, you did the work today. You had now have thoughtful conversations you can take away with you. You can figure out how this data works for you, works for your community, how you can use it to change the world. You showed up today, and thank you.
Thank you. All right. Thank you all, and hopefully we'll see you in community soon. Take care, everybody.